Hi there, I'm Jen Lewis. I'm a medical statistician from the School of Health and Related Research at the University of Sheffield. I'll be talking about some preliminary findings from some routine data regarding attendances at emergency departments after a phone call to NHS 111. So the NHS 111 telephone advice and triage service was set up to improve access to urgent and emergency care, or UEC, for patients in England and direct them to the correct level of care to provide for their health needs. The NHS long-term plan is committed to NHS 111 as part of an integrated urgent care approach to reduce pressure on hospital services. A national evaluation using a controlled before and after design demonstrated associations between NHS 111 and increased use of some UEC services. However, there is a lack of evidence on the impact of 111 on subsequent use of hospital services, particularly in studies using linked data to follow individual patient episodes. The aim of this analysis was to measure attendance at emergency departments and subsequent hospital admissions up to 7 days after an NHS 111 call. We used the Cured research database for this analysis, which includes routinely collected healthcare data for all NHS 111 calls in the Yorkshire and Humber region from the beginning of April 2013 to the end of March 2017. It also includes data concerning A&E attendances and all emergency hospital admissions from 14 NHS acute trusts across Yorkshire and the Humber. This data was linked primarily using NHS numbers and date of birth. Full HRA ethical approval and additional Section 251 HRA CAG approval was received to process identifiable patient data for linkage, after which the dataset was pseudo-anonymised. We examined records for all NHS 111 calls made for adult patients aged 16 or over in this dataset, and for each call we explored whether an emergency department attendance was made by that patient within 7 days of the call, and if so, whether this was followed up by an emergency admission. In addition to an overall analysis, we also looked at subgroups of patients according to the initial disposition from the 111 call, which age bracket the patient was in, whether the patient was advised by a clinical call handler or not. Specifically, we looked at the percent of callers referred to each disposition, the percent of callers attending ED following the 111 call, the time it took those patients to attend ED, the percent of attendances that were classed as non-urgent, and the percent of subsequent admissions. The database yielded a total of 3,631,069 calls for patients aged 16 or over across the Yorkshire and Humber region. The majority of these, around 60%, were referred to seek primary or community care. These patients accounted for a much larger percentage than the second largest group, with just over 15% of patients receiving instruction to self-care and not being referred to any other service. Less than 10% of patients are referred directly to ED. We found that a substantial number, about 23%, of patients who call 111 attend ED in total. Unsurprisingly, patients who are sent an ambulance by the 111 team are most likely to attend ED, followed by those who are told to seek care at an ED. However, a surprisingly large proportion of those referred to primary care or to self-care choose to attend ED regardless of the advice given to them. About 10% of those referred to primary care and 20% of those referred to self-care. These account for almost 40% of ED attendances following a 111 call. We also found that of those attending ED within 7 days, almost all do so within 48 hours. A very small number attends after this time, and virtually all of these were originally referred to primary care. So it's possible that these patients have attempted to access primary care in the intervening time and have either been unable to do so or have been subsequently referred to ED by a GP or other primary healthcare professional. Looking further at the time taken to attend, it's clear that a large majority of patients attend ED within 4 hours, which is indicated by the red line in these plots. For patients sent an ambulance or those referred to ED, virtually all attendances are well within 24 hours, which is indicated by the blue line. This is also largely true for those originally advised to self-care. However, for those referred to primary or community care, there is a noticeably heavier and longer tail of the distribution of times to attend. This further suggests that some of these patients may have accessed primary care or attempted to in the intervening period. So when we look at those patients who do attend ED, regardless of their original disposition, fewer classed as non-urgent. This suggests that in general most patients who attend are correct to do so, even if they are originally told to seek primary care or to self-care. What is also quite striking is a large proportion of admissions across different dispositions. So we see admission rates of around 30% or more for all dispositions. But strangely, with the exception of those referred to ED originally, we might expect that those referred to ED would have generally more urgent problems and we'd see more admissions, but this isn't the case. Of particular interest is the high number of admissions from those originally referred to primary care. This is around 40% of those attending from this disposition, which accounts for around 28% of all admissions, whereas only 8% of admissions were originally referred to ED. So we broke patients into 3 age brackets to look at differences across age groups. These consisted of patients aged 16 to 44, aged 45 to 74, and those aged 75 or over. Perhaps unsurprisingly, we found there were fewer referrals to primary care or for patients to self-care with increasing age. In contrast, more older patients were sent an ambulance or referred to other healthcare services. Interestingly, fewer older patients were referred to ED, which is perhaps due to increased barriers to transport or greater concern regarding patient welfare with increasing age. While there were differences in the profile of referrals, however, some similar percentages of patients attend ED from each disposition regardless of their age bracket. So in total, around 21% of patients in the youngest age bracket attend ED compared to around 28% of patients in the oldest age bracket. We found a noticeable difference in the relative percentages of ED attendees that were subsequently admitted to hospital in the different age groups. Far higher proportions of older patients are admitted following an ED attendance than younger patients. Again, this was regardless of the original disposition, with nearly 60% of older patients who attended ED that were originally advised to self-care being admitted. This is in contrast to the same group in the youngest age bracket, of whom just over 20% were admitted. In all age groups and across all dispositions, there were relatively few ED attendees who were classed as non-urgent. Indeed, all but one subgroup had larger and often much larger proportions who were subsequently admitted than were classed as non-urgent. Interestingly, the largest proportion of non-urgent patients comes from the group who were originally referred to ED and thus might be expected to have more urgent care needs. Again, this was true for all age groups. The main differences we found between clinical and non-clinical call handlers was that clinically trained advisors tend to refer fewer people to primary care or to other care services and more to care for themselves. This might reflect a greater confidence in determining minor health issues. Generally, there were few differences in the proportions of patients attending ED from each disposition, regardless of the call handler's expertise, although callers seem slightly more likely to take advice to self-care when advised by a clinically trained advisor, which may reflect more faith in the advisor's decision. Generally, there were few differences in the overall profile of those patients admitted to ED or those classed as non-urgent, regardless of the type of call handler. In all but one group, more patients were admitted to hospital than classed as non-urgent, and often markedly so. The one exception to this, as before, were patients who were originally referred to ED, in this case those who were referred by a non-clinical advisor. The main difference between clinical and non-clinical call handlers is the proportion of patients referred to other services. In this group, far more attendees who were referred by a non-clinical advisor are subsequently admitted to hospital. This may reflect a better understanding held by clinical advisors of other services available and the appropriate circumstances under which to refer patients. However, there are relatively few absolute numbers of patients in this category, so this finding should be interpreted with a little caution. So to sum up, we found that large numbers of patients who contact the NHS 111 telephone advice service and who receive a low acuity disposition, including primary or community care or self-care, subsequently go on to attend ED. Furthermore, a large proportion of those attending in these categories are subsequently admitted to hospital. Some further questions clearly arise from this investigation. For example, it is unclear why so many patients referred to low acuity dispositions attend ED. It's possible that a number of these patients are accessing primary care and being further referred to ED, or are attempting to access primary care first. However, the extent to which this is the case isn't possible to ascertain from our current data. It is particularly important to understand why such a large proportion of those referred to primary care or advised to self-care are subsequently admitted to hospital when they do attend ED. These patients are clearly urgently unwell and in many cases should probably not have received a low acuity disposition. So further work will attempt to elucidate the reasons for this. It's also unclear why relatively few patients referred to ED are subsequently admitted to hospital if they do attend. In future work, we'll try to explore differences between those who are and are not subsequently admitted and those who are classed as non-urgent to reveal insights about referral trends to this disposition. It's of interest to explore the differences between age groups, specifically whether older patients are less likely to seek help for less urgent health issues, or whether call handlers and emergency care doctors are more cautious in their referrals and admissions of older patients. The lack of differences between clinical and non-clinical advisors is also of interest. It may be that clinical call handlers deal with more complex cases, and so the accuracy of referrals may not be directly comparable. This is something we also plan to investigate further in future work. So thank you very much for listening. Please do leave any questions or feedback in the comment section, and we will endeavour to respond as soon as possible.